First of all, I would like to ask you to take your mobile phones, go back to Menti, and put in this code. And I'm going to talk about Chemsex at the end of my presentation, if we have some time left. I'm going to speak about a gentleman who presented about a year ago to our unit, and he was quite ill. And do you have it? Not yet? Okay. So it will be a journey from Chemsex to intensive care, and not yet, not yet. Okay, yeah, so whenever we will not vote immediately, but throughout the presentation, because difficult cases are usually managed in a team, and now you are on a part of our team, and you will be helping me in deciding what to do. So should I go on? Yes, and actually, in the initial presentation, Say had about 25 people responding. I hope I will beat him. So you help me. This gentleman, 47 years old, fit and well, no significant medical history, presented with some history of upper back and neck pain and some weakness while walking. No other symptoms. He was given analgesia by his physicians, and he was sent home. But he gradually deteriorated over 4 weeks' time. And when he was unable to walk unaided without a stick, he was admitted to hospital. In hospital, we get more history. He's a gay man. He's got one male partner. He doesn't change partners. He's employed. He doesn't have any travel history, and he occasionally injects methamphetamine and uses oral sildenafil Viagra for sex. And he occasionally drinks alcohol. On examination, he's fully alert, cooperative. He's got spastic quadriparesis. He's unable to stand up from sitting, and he's got urinary retention quite significant. His bloods are not really remarkable. His syphilis serology is positive, and his HIV test is reactive. So now we would proceed to do routine things like CT head, lumbar puncture, and we would prepare for IV penicillin to treat syphilis, and we would discuss starting antiretroviral medication. Any suggestions? What are we? Is there anything that you would add to this management? You can shout. Spinal MRI. Okay, so spinal MRI. Anything else that you're missing? Sorry? CD4, we get that, yes. Just routine. I mean, we did routine things, and we'll do it. So, CT head, unremarkable. Lumbar puncture, protein, very high. White bloods, not really that high as you would expect with this protein. And glucose in CSF about half of what it was in serum. And lactate, unremarkable. And so we did chest x-ray and started IV penicillin. What else would you add? What is missing? What are you missing? What would you do in your practice? Okay. Lyme disease. TB. Okay. Well, we did CD4, as Victor suggested, and he's got 340 cells. His viral load 250,000, and viral load in CSF pending for HIV. And now let's go to the HIV. Let's forget about the patient. And now when would you start antiretroviral medication in this? Would you start immediately? And if why? Would you start in 2 weeks' time when the resistance test is back, or rather later after you treat syphilis and do MRI and things like that? And I think that we should have our vote. Okay, take out your mobile phones. We switch to the voting. Okay, 14, 15, more. 25 is the benchmark. We need to get over it. 23, good. 25. Yes. 26, yeah, good. Okay, so majority would go immediately. Why would you go for that? Sorry? Why wait? Well, resistance test. Treat first what is infective, what is not right, because of I would hesitate with throwing all the medication in and having some adverse reaction rash and you don't know what's going on. Okay. He's unwell. Yeah, he's. It could be, yes. It will be actually HIV-driven quadrupary neurology. So.
Thank you. For TB, because if it's TB, you will have to deal with that. So the PCR from the CSF will be the only thing that I will wait for.
Yeah, I think there's no one good answer. There's good options. And let's go back to our presentation. It was extremely high protein. Could we go back to my slides? Okay. So the next day, before we made the decision, we discussed, should we wait a little bit or should we go immediately? Next day, the patient decided for us. The next day, he was quadriplegic, unable to move all his limbs, and he had severe neck pain, unresponsive to opioid analgesia. So we went on with acute MRI, and it has actually shown mass lesion in his spine, in cervical spine, and this epidural abscess compressing his spine, explaining his quadriplegia, and this plump of infective mass in front pressing his esophagus, and it's a C5-6 destruction. What is your differential now? Okay, Miloš, say it.
He has history of Chemsex use or not?
Yes.
So
this is presentation.
This may be a classical staph abscess. This may be a mass lesion due to lymphoma. This may be other gastroesophageal cancer, classical one. Probably he's also smoking, so he may be in the risk of this one. Obviously, this could be also tuberculoma because he has had a high protein level in the CSF. Fungal was probably, I would not think it as a first line, but also consider this.
Okay, let's move on. Okay, this is the answer. I thought you would say TBS first because it was gradually developing cold abscess. That's what we thought, and we were surprised. But yeah, Chemsex can end up in our intensive care unit. Staph aureus bacteremia, and the pus from the spine was also PCR positive for Staph aureus. So now he improved. His arms were started to move, and he had we were considering spinal stabilization. And 3 days post-op, we did follow-up MRI, and it has slightly improved this blob in front, but the spinal compression is still significant. We discussed with our neurosurgeons if they would put some rods and clean it and stabilize it, and they refused it. The official explanation was, and I think was quite reasonable, that the infective mass is actually involving the esophagus, and in case they get there and cut the esophagus, it's end. There's no way how to get out of it. Say? This is bad. Yeah. Yeah, he was given steroids. He was given. We sent it. I think we sent it. But it was not PVL. Yeah. But at this moment, we didn't know it. PVL is Panton Valentine leucocidin, toxin of Staph aureus, toxic version of Staph aureus. Okay, so now we're back to our vote. Gentlemen with quite good CD4 count, viral load, and Staph aureus bacteremia, deep-seated spinal infection. When would you start antiretroviral medication? Would you start immediately, or would you start later, or 2 weeks time as the guidelines say? So basically, the TB that we considered first is probably ruled out. Everyone immediately. Without resistance test? Gentlemen in intensive care? Okay. Do you know what we did? We started immediately. Could we get back to my slides? I'll get to it. That's a good question. Integrase inhibitors, we start with from the youngest, very low individual percents, and then RTIs about 3 to 5% for naive patients, and NRTIs very low numbers. So it's not really an issue. Okay, now this is a busy slide, but this is from the guidelines, from the top, the first line, and then alternatives, and the bottom is other alternatives. What medication would you, so we pretty much agree that you would start immediately. What medication would you give? And let's go to our votes. Take your mobile phones. You saw the MRI. You saw the MRI. He's quadriplegic. He's able to move his arms like this. When there's something itching on his nose, he has to ask nurse to do it for him. Okay, so Truvada dolutegravir is leading, and bictegravir would be okay. Okay. Efavirenz with Kyvexa. That's a nice one. And boosted darunavir, one person. Okay, so looking at this, so pretty much we have 2 people with efavirenz-based regimen with whatever nukes, and 1 person with boosted PI, and the rest would be either bictegravir or dolutegravir based with nukes. At this moment, we didn't have HLA 5701, so we did not consider ABC. But if there would be reasons, Okay, someone added Combivir and efavirenz, and I would like to get back to it later, because that's not in the guidelines, but I think it's still sensible regimen for certain scenarios. Okay, 26, good. I'm beating you, say again. But it's including say, so he's against himself. Okay, let's go back to my slides. Okay, so what do we consider when we choose antiretroviral medication? Potential drug interactions, that's why we are here. So proton pump inhibitors, he may need it. Rifampicin, because if the surgeons would operate on him, put some metal, we would like to protect biofilm and give him rifampicin. If we are satisfied he doesn't have TB, which at that moment we're quite satisfied. Yeah, that answers the next question. Linezolid in case of MRSA, that's another thing. And being suddenly quadriplegic at age 47 and not becoming depressed means mental health issue, a big one. So there was something also we have to think about. And as I mentioned, efavirenz was one of the things that we thought about, but then decided against for few reasons. Potential of developing renal failure while septic. So if we go for tenofovir-based regimen, where is this EGFR and where it will be in 2 weeks' time. And also, as suggested, with this plump in the throat, how will he swallow, especially if he's laying flat? Okay, and now here is the, actually not the interactions checker, but next to it is prescribing resources. Well, you see it in the middle. And anyway, you go by either patient characteristics or therapeutic indication. And therapeutic indication, anti-tuberculosis drugs, and we go for rifampicin, but we've seen it in previous presentations, so I'll skip it. But the thing is that PIs, especially boosted regimens, are difficult, and from NNRTIs, only efavirenz would possibly be acceptable, otherwise nothing. And patients with swallowing difficulties by patient characteristics. And this is the table. It's about 4 pages that you can go and look at it. And so, to summarize, IV form, people in ICU, you can either feed them with crushed tablets or liquids or IV. IV is zidovudin and ibalizumab, which I don't know if you have available. We don't. So it's maybe in the future, but it's indicated for patients with multiple resistances, heavily treatment experienced, where there's no other option. So probably that would not be the case. Liquid form available for quite a few of those medications. The problem is, does your pharmacy stock it, or do you have to order it and wait about 3-4 weeks time? And crushing tablets in summary of product characteristics is officially allowed in efavirenz, ABC 3TC, so Kyvexa, and 3TC zidovudin for Combivir, and Truvada TDF FTC can be dissolved in orange juice or water, and etravirin could be also dissolved in 5 ml of water and then put in a larger. So you can actually drink it, have a liquid form. What is not an SPC, but there is a good pharmacokinetic data, are dolutegravir in form of Traumec, and we have some good TDM data in crushing in healthy volunteers as well as in sick patients, and TAF FTC darunavir with cobicistat, and also TAF or TDF FTC with elvitegravir. So these tablets can be crushed off-label, but still. Okay, so again, voting. What medication would you choose? And because of time, let's skip it. let's skip this because you pretty much agreed on what we did. We decided dolutegravir and Truvada because you can crush dolutegravir and you can dissolve Truvada. And there is about 5% background NLRTI resistance, otherwise it's fine. And especially the biggest on the bottom line, these drugs were available same day from the pharmacy, which sometimes is, you know, you can think about science, but when you call the pharmacist and say, yeah, we'll deliver it next month, to the end of the next month, all the science pretty much goes out of the window and you have to think something that is more sensible. Okay, so this gentleman, viral load undetectable in 6 weeks, then we simplified and got him to Triomec. He was treated for 3 months with antibiotics. He got full arm strength and legs are still paretic. He's continent of feces and urine. He's occasionally self-catheterizing. And could we have the video now? This is him last Friday when he came for a follow-up in our clinic. When we were shooting this, afterwards I asked him, you know, I have to give a presentation about Chemsex. Could you tell me something about it? And he told me a few things that I'm going to tell you. Let's stop it and go next because, yeah, let's go back to my slides. And he said that when I asked him, you know, after you have been through all of this, are you planning to engage in Chemsex again? And he said, well, I'm not. However, I cannot guarantee, and if the occasion arises, I'm not really sure. So let's go. What is Chemsex? And now, what is your knowledge of Chemsex? And let's vote. Let's vote through the phones. Let's not raise hands on this. Could you go to the last voting? Who? Yeah. Good. Well, 21. Okay, those 5 or 4 missing, they don't want to admit that they have done it. Okay. So I think this is pretty much, we have a little or moderate experience and very little first-hand experience. 32, that's the best vote ever today. Majority, the best participation. Yeah. Who cares about ARVs and treating 2 weeks or immediately, but Chemsex, that's interesting. Okay, let's go back to the slides. I think that, let's go to the definition. Consumption, Chemsex is consumption of psychoactive substances to facilitate or enhance sexual activity. So many of you looking at the picture have done it without knowing it is Chemsex. Okay. I've put intentionally this background because when you talk about certain activity, there's always a spectrum. And when we go from the lightest forms to the darkest forms, and the Chemsex I'm going to talk about with our HIV cohort or gay population is usually somewhere in the middle. It's sometimes called party and play, online dating, and dating apps are helping to it. And Chemsex should be aphrodisiac, stimulating, and anxiolytic. What happens when people get hyped up? Sometimes they say high and horny. What happens? Cognitive disengagement. So they do things that they would normally not do, and they don't care. And also there is disinhibition, and the level of disinhibition is variable, and so that sometimes, as I was showing in my case, in our patient, that it could be called party and play and pay. And what how do people pay for chemsex? Condomless sex with multiple partners usually results in injuring practices, infection, and crime. One of our not this one, but another patient who got involved in chemsex, and I discussed it with him. It ended up that he had no sex and he was completely robbed of all of his money and savings because he invited the party to be in his home. And the long-term effect of that is inability to have sober sex, so basically have sex without chemicals. The thing is that, as we discussed with this patient, that the stimulating agents get increase the sexual drive or appetite or desire, and they get erection for 6 or even 6 hours or more, and with methamphetamine, what happens with their with the mind, with human brain, is that people have compulsive behavior. So some people, when they get a shot of methamphetamine, they start cleaning, obstinate cleaning, and if they're in a sex party, they start performing sexual activity, and they can go for days, and sometimes they have very high, really going for days and changing multiple partners. And the thing is that methamphetamine actually causes erection but slows down ejaculation, so they can go for hours without end. Okay, so these are the meds most often used. So it's crystal meth, mephedrone, and sometimes cocaine. The G and alkyl nitrates are considered, and with ecstasy, as a party drugs. The problem is that you never know what you're buying. You cannot go on the face value. So there's lots of cases of overdose, and some overdoses can be lethal. And ketamine in medical field is used for because of its dissociative properties, for unpleasant procedures like endoscopy, and in some practices is used for those who are on the receptive side of the intercourse. And sildenafil, vardenafil, and tadalafil to enhance the erection. Okay, so, and let's go back to the Liverpool website. We can find potential interactions with different drugs, and also there is ARVs and recreational drugs. And the question is not to be or not to be, or to do or not to do, but is patient willing to adjust lifestyle to their medication, or do we need to adjust medication to their lifestyle? And it takes a good sit down and discussion, a full history of drug use, and maintaining this trust between you and the patient. And because it's usually they tell our nurses much more than they tell to us. And if the nurse will whisper, ask about this and about that, and they know that we know, we're able to open, and to a degree that we feel comfortable, we're able to discuss openly. And and then we can discuss health risk associated with chemsex drug use, and warn them about being robbed, being raped, being killed, being overdosed, or getting addicted to it, or getting infected with Hep C if they're already HIV positive. and then we can discuss if they don't want to stop, switch antiretroviral regimen with low interaction potential if appropriate. And this would be for my presentation. I'm open to your questions.